Now I request my teacher, my mentor, Dr. Sathyan sir, to speak to us on BANG and KDB in MIGS.
Thank you, Ganesh, and thank you, Bindu, Namita, and KSOS for this wonderful opportunity. I just have a question to all of you. How many of you are here practicing glaucoma? Just raise your hands. So, 4, 6, 7, 8. Okay, 8, 9. Okay, all three of you are. So, how many of you really want to do MAGS from? What kind of an MAGS you are already doing? You are not doing it. Okay. So what is the procedure that you would like to do? So based on that, I will just modify my talk. What is the procedure that you wish to do? Because I feel MAGS is already been an overdose in every meeting, every session, mostly all of you have. So if I can just be very specific to you, then I'll be really more than happy for you. So what is that you wish to listen to? Because Bindu has already almost 99% she has covered my talk, and she has given me the KDB as one of the cost effective options. I'm not sure what was running in her mind. The KDB people are also here, so they wish to give you all free KDBs. So I have to understand that. So BANG definitely is a cost effective option. How many of you have heard Keith Barton's talk on Thursday? Okay, super. So Keith Barton's talk was very nice, very practical talk. For them, the MAGS procedure seems to be, he was not in favor of MAGS other than the pressure flow, which he feels is working. But all the remaining procedures other than the GAT, he said is not that great. So at least for your understanding here, we need to understand the BANG and the KDB. Is it really truly effective, or how far we can really look into that? We can understand. So we know that it is not for those who are having an advanced glaucoma as a primary procedure. Mild to moderate disease where they are on probably one or max of two medications possibly, but I would prefer one medication, where they wish to go for a cataract procedure. This is one of the options that you should look at as a primary choice. For us, the second choice now is becoming more and more of those who had the failure of surgeries, failure of medications, where you are running out of options. You can select this as one of the other additional procedures, like GAT could be one of the procedure where you can have the maximum IOP drop. Having said that, BANG may not be the ideal procedure for that. To an extent, possibly the KDB may be an additional option that you can have. So just keep this in mind as a primary thing. Am I going to do an advanced cases, the BANG? Please don't do that. Or KDB may not be the choice. Mild to moderate is fair enough. So as Bindu has mentioned all this, understanding about the anatomy, for your initial cases, please do not select anything with an angle closure disease. You might say, once I put viscoelastics, the AC will deepen and then I can see all those things. Don't play around. See a patient who really has a good anatomy, where you can really see the trabecular meshwork properly. So these patients, you will have the confidence, because without your anatomical knowledge, you try to do something, you will end up with messing up the entire show. So don't do that. If you have a bit of a tremors, make sure that you take some tablet for your tremors and then do it. I'm not sure Bindu could understand what Andrew was asking you. Andrew was asking what kind of a movement when you go inside you do. Is it, just watch my hand, there are two movements that you do when you are doing your images. One is take this and then move it like this. One is, it is like a pivot, you keep it here and then move it like this. So this is what he was trying to ask you. So when you do this, you don't have the control over this. People try to tell you that we have to keep this center and then try to move it. Probably we can withdraw a little bit because this side when you move, the angle comes a little forward. So you have to keep it like this and then move it. So I'll show you probably one KDB video, which is not mine. I'll show you that. So it comes very nicely. I was also trying to do that, but it is not that we speak, it is easier. But when we do, it is not that easy. That we need to understand. So once you see this kind of an angle, this is the ideal patients where you can really select. So you will be more confident in doing the procedures. Nothing wrong. Don't try to say that I'm doing so many KDBs or so many things. Don't do all those things. First is our learning process. So it starts with selecting the patient as a proper patient. And as Bindu was mentioning, keep on doing more and more direct gonioscopes on the table in all your phaco cases. So you keep learning. So how to remove the air bubble. So whatever we teach is different, but you have to use the high viscous viscoelastics. You will have mentally, we all have some kind of restrictions in not doing so, but make sure that you do that. You put the viscoelastics, high viscous both for anterior chamber as well as on the cornea. So once you identify the blood in the slumps, that is the trabecular meshwork area, then you are there. So that is one clue which you should take it so that you can use it. On the table, make sure that at the last moment, you should not be searching for your eye prism because they would have sent it for a sterilization. They will say, madam, only tomorrow it will come. So don't do all those things. But I have all that gonial lenses, prisms and everything, whatever possible is available, I have it. But it is not enough for you to just have one. Make sure that you get it from KDB people, you get it from IC63 people, everybody. You can request them to give you so that you understand better. I'm not sure, as Bindu, you were mentioning that you could do it under a block. I'm not sure whether you are able to do it. Maybe Ganesh is doing also, I don't know. But I can't do it under block because eye movement is not there. When you're asking them to move towards the nasal side, when you block, you may not be really able to move it. So I personally prefer to do it only under intracameral 1% xylocaine, preservative-free xylocaine that is available commercially from Sunways and Entar. You can use it, but otherwise, always when you finish the phaco, make sure that you re-inject again the local anesthetics. Otherwise, the patient will feel the pain. Definitely will feel the pain. But topical paracaine, I am not comfortable, but I use only the intracameral. So it is your personal choice. High viscous viscoelastics and of course the needle. Bending the needle is actually it is towards you. So I'll just show you the needle bending for MAGS. So I'll just run it a little faster. So the needle bending is towards you. The bevel is there, bevel is towards you. Usually for other things we bend it in the other way. Capsulotomy you bend it in the reverse way. Okay, so that is how you bend the needle 90 degrees approximately. You can always just adjust it a little bit for your own convenience. And this is the BANG procedure. This is one of my initial procedures. It is not that easy as we think. Mentally it is everything looks very easy. When I started doing my ICCA, everything was looking very simple, but once I start doing, only the capsule will come, the lens will be there. So something like that. So so you can see the angulation is not that great and the visualization is also not that great, but you slowly learn. So this is how I was telling you. Initially you will not be able to understand what you're doing because the feel is different. Slowly you start doing, but don't tell the patient entirely only by doing BANG that your IOP will come down. Probably you may have to go with your trabeculectomy in those initial cases. Then you will start learning. So I'll just directly move on to the KDB. This is my personal video, but I have one more video which seems to be better one, so you can understand better. I'll show you this. So this is actually Kahook's video. So we'll have a talk from Kahook in January middle we have. I have spoken to him. So he has agreed for the talk. So there's one initial movement. little bit, and then, so this is a perfect eye to have, something like this. So I'm sure that most of us, we don't get every case like this. So if it is like this, it is quite easier, and once you have done that, you will have that tubercular meshwork, that membrane will be there. Make sure that we go and remove it. So removing with this forceps is a real task. So you have to use that alkaline the forceps, that you can easily remove that. So removing this, not every time it is possible. Sometimes we may not be able to remove with this forceps. These are our regular capsulotomy forceps. That is not good enough for us. And then you can see initial cases when you have anterior and other anterior segment OCTs. I don't know how much you can do it, but see this, how much you have really cut open that area. So I keep doing that in every patient. I am just watching 1 day, 1 month, 3 months. I am keep watching, but many a times we really have not cut the entire area. We have just cut part of the areas. Part of the areas are not cut open. So we have to keep on practicing. It is just a matter of time that you may perfect at some point in time. But don't think that every patient of what we do, we sweep it. It is not that we cut it across all the time. So this will give us a lot of ideas. We are still learning. I won't say we have already learned everything and then we can teach you the entire story of things, but we are keep on learning. But at one point in time, as of now, the KDB definitely works to an extent. BANG is relatively okay. iStent also works to an extent, but we'll have to see. GAT as of now has the highest IOP drop in all the procedures. Definitely that is a cost effective procedure. When you are doing the KDB, as of now, we are not going to use it only for one single patient. When we use it for a couple of patients or few patients, then definitely it works out to be a cost effective procedure. So thank you so much for patient listening.
Thank you, sir.